has written a book which is all about envisaging a much more radical, holistic approach to how the NHS provides health services and how care could be part of that, but also how we think about it, the social justice implications, and also really the finances of it. It's a big, ambitious look at the whole thing. I will actually bung the link to the book in the chat so you can all have a look at it. Make sure to buy yourself a copy and everybody else. It's called 5 Health Frontiers. And so I think I'd just like to say welcome Chris now and say hello. Hi, Chris, do you want to unmute?
Hi, everyone.
And this book is really handy, especially in the way that it talks about, well, really, he's segmented it into these 5 health frontiers. The first one being the NHS frontier, the second one being the social justice frontier, the third being the economic frontier, the fourth being the social care frontier, and the fifth being the sustainability frontier. And then, ambitiously, he recommends or proposes a public health New Deal, which is a much further reaching conceptualization of everyone's well-being than we have become made accustomed to, shall we say. Perhaps the ambitions of defending the NHS as it is are not actually ambitious enough. But I think we also talked about there were sort of 5, I'll put these kind of discussion topics in the chat as well to help us kind of think. There we go. Which very quickly, it's growing waiting lists, the weaknesses in the care sector, the very high mortality of disabled people during COVID, the structural factors in health inequality and care, and also analysis of how, in this case, talking about how climate activists have gone from a sort of defensive posture to an offensive posture, to be more radical and to actually dream of a different system and go for that rather than being in a constant defending something that's slowly being chipped away at by successive administrations, maybe. But anyway, that's me blathering on long enough. I think we'd like to hear from Chris and your book, and maybe if we can start with the issues that you know, how people experience the crisis of the NHS in growing waiting lists, delayed surgeries, and the increasing then number of people living with impairments, conditions that mean they are increasingly living with pain and various other situations that are really impacting the quality of their life.
Thanks, Rick. And a big thanks to Inclusion London, Cheshire Disabled People's Panel, Greater Manchester Coalition Disabled People for putting this on together. It's brilliant to be able to talk and to share some of the book with everyone tonight. And thanks for joining on a what looks to me out the window as a fairly dark Tuesday evening as well. So really good to be having this conversation. So as you say, Rick, the kind of starting point really here is really about where we find ourselves 2 years on from the start of the pandemic. And I think the idea really behind the book was not in the way that we've seen kind of other books do, focus too much on the decisions that were taken during the pandemic. I think there are some brilliant exposés of how things like following the science and late lockdowns and all the kind of public health measures of those 2 years have impacted where we find ourselves today. But there's also a second job, which is using that insight to imagine the future. And I think that's a more, in many ways, a less often turned to job and an equally important one. And so if we think about where we find ourselves, we have kind of 2 things in track, I think. One is very, very kind of severe, extensive waiting lists for care, as you say, and research just out last week that came out from my Institute for Public Policy role rather than my book author role, audited some of what we're seeing in terms of the NHS. So going through a couple of case studies, we can look at cancer care, and the key finding there was that activity levels have dropped anywhere from 7 to 25% in cancer services. There's been a 3% drop in the number of cancers diagnosed at a highly curable stage. So that will have a knock-on impact. And that will take 10 years on current trajectory just to get back to what was not a really great 2019 status quo. The research shows that people living with dementia are not receiving anywhere near enough care plans or care plans reviews. There's been almost a halving in the rates that those are undertaken. And in mental health services, we're seeing a big spike in eating disorders in children and young people with suicidal thoughts, with depression, and a really alarming increase in the inequality in depression rates as well. So, the highest in our analysis was amongst disabled people, overwhelmingly the highest rate, and lots of difficulties around access. So a really, really difficult situation in terms of health and healthcare services in the countries. That's where we find ourselves.
Okay, I'm just had a note in the chat from Rona saying your sound is distorted and can we just slow down a bit? So we'll try and speak slower, and I'm not sure about the sound distortion. It's okay for me. It suggests that might be bandwidth issue for some people. But so what we'll try and do is speak slower.
Sure. Well, let me know how it goes. So
please carry on, Chris. Sorry.
No worries. No, not at all. So we can look at that status quo of where we find ourselves now, and I like to contrast that to a story that emerges in the 1920s, and this is where the Five Health Frontiers opens as a book, and it's the story of Eric Blair, George Orwell as we now know him, traveling to France, a trip that was quite common for literary figures of that decade. And Orwell travels to France under the kind of promise of the city of lights, of the hedonistic cafe culture that others in his cohort, people like Ernest Hemingway and John Rhys and T.S. Eliot had travelled over advance of him for. Except that Orwell's experience is not of those things, it's of the French healthcare system. George almost immediately on arriving in Paris develops what hasn't been formally diagnosed, but a respiratory illness that is most likely pneumonia, but we don't know that for sure. And that takes him into L'Hôpital Cochin, a French hospital that still stands today, although its reputation is far better. And what happens to Orwell is he comes in with a very, very high fever. He's interrogated for 20 minutes by the receptionist to decide whether he can come in and be treated for free. He's marched in a robe, a dressing gown and slippers, the kind of uniform of the hospital, across a February evening's courtyard in France. Not a warm experience. And
hi, sorry, Alexandra, did you need to say something? Or
sorry, Chris, that was my mistake. I was muting people because of the background noise, and I accidentally muted you.
No worries, no worries, no worries at all. So finds himself in a set of beds 6 inches apart, watching no privacy curtains, watching other people have their operations. And he describes in his recollections of the incident a smell of feces and sweetness that fills the room. And it leads Orwell to compare the experience there as more akin, an institutional experience, more akin to the torture chamber or the prison than to the kind of gleaming white vestige of the NHS in many people's imaginations today. And what's interesting, I think, is that often, if we think about those kinds of experiences that happen before the NHS, the existence of the NHS leads many, particularly, I think in the book, The Five Health Frontiers is written for a left campaigning audience, not necessarily a left campaigning audience with experience and specialist knowledge of health and social care. It leads many to think that the issue has been won, that the NHS being founded was enough to humanize our approach to healthcare and to get past the issues that people like George Orwell wrote so powerfully about in advocating for the NHS at the time. But of course, we see in the contrast that things aren't brilliant, things aren't perfect. The sheer and simple presence of a National Health Service isn't enough to undo the kinds of inequality and difficulty, the experience of waiting with maybe anxiety or pain that many, many people experience. And I think that trait is very important because it challenges us to think slightly differently about campaigns on healthcare. And I think it challenges us to think differently in two ways. In both cases, the thing that we need to look past, I argue, is a defensive approach. And I think that defensive approach often has two traits. First, it's very focused on defending what we have from being taken away. So the most common campaign that we see in health is against the spectre of the sell-off. The idea that we might wake up, whether because of Thatcherite denationalisation or the health and social care bill that's currently going through Parliament or an American trade deal, to find the NHS sold off overnight. The second is that the focus is almost exclusively on the NHS because it's considered the thing that's transformed health and care from the Orwellian torture chamber prison cell to something much fairer today. The focus is very exclusively on defending the NHS, but looking very inwardly at the NHS, not looking maybe at all the other things that define a healthy life. And I'd include social care in that bucket. But there are signs today that that approach is now struggling to work. And it's struggling to work not only from the kind of inequality we see, but I think it's actually struggling to defend the NHS. I think the idea of now defending the NHS is one of the biggest risks we have to its future. One of the things that's happened over the last few years and that COVID-19 has accelerated very, very quickly is not so much the risk of the NHS being sold, although I do agree it's very important that that doesn't happen, but rather people opting out of the service. So faced with really long waits, some of the numbers I've just talked about in terms of access and outcomes, faced with maybe the anxiety of not being able to get a GP appointment, the pain they might be waiting in, people are choosing, instead of taking up their public entitlement to free healthcare, to go private and to choose private alternatives. And that doesn't have to be thousands of pounds spent on an operation. That could be £50 for a same-day GP appointment. That could be £350 for a specialist appointment. What is clear, though, is that when we look at the data, the UK, having been the G7 nation that was the most likely to fund its healthcare services through tax in 1970, it's now the fastest rising G7 nation in terms of private funded healthcare. So money coming from private individuals' bank accounts. And 2020, the first year of the pandemic, and the latest data we have suggests that rise was fastest that year of any year in the last 50. So people moving away from the NHS themselves, which is interesting. And it's a real problem, I think, because One, it threatens to widen inequality, but two, it also threatens to diminish the political coalition that stands behind the National Health Service. So we can see the kind of trajectory if we look at, say, more conditional benefits. So if we look at employment support benefits, for example, unemployment cash benefits, and compared to the NHS, which has been almost universally supported, that more conditional system that doesn't benefit everyone, that not everyone sees a vested interest in continuing, is subject to wild spikes in public attitudes. And that has left it open to budget cuts, to often very poorly thought out political whims. And there's a risk if the opt-out continues in the NHS that the same thing happens, that breakdown of public support for the health service continues. So I think we need to think very carefully about what our response is in the years to come. For me, and this is where the 5 health frontiers come in, there are 2 ways to think about that. One is that we need not a defensive position of save the NHS on the basis that, you know, if we do that, it doesn't get any better, therefore people will opt out. We need a more offensive campaign that reinvigorates the Bevanite founding principles of the NHS for the 21st century, that puts forward a distinctly left agenda for what the future of the NHS looks like beyond the fact it exists. But the second thing I think we need to think about is where the NHS can't do everything on its own, and where, in fact, learning from the pandemic, we have the opportunity to look outwardly and think about how other key areas of health and care and all the things that determine them can be employed to deliver better health in some for everyone, but also a much fairer distribution of that health. And that's the basis really for the Public Health New Deal. So I wanted to touch on a couple of the frontiers. I think going through all 5 might be a bit much for an hour, but to touch on a couple of the frontiers as they exist. So I wanted to start really with social care. And I think social care sits as an interesting area in the book because compared to social justice, the social determinants of health, public health, the interaction between health and our neoliberal economic model, social care is one that actually there have been some, particularly thinking about the 2019 Labour Manifesto, some policy proposals. So it's an interesting place to start. I start the thinking on social care in the book by thinking about some of the big structural challenges that we face in social care. And I think 4 of them really stand out. There's obviously quality as a starting point, the standard of care, particularly in terms of public provided care. Stats people on the call, I'm sure will know inside out, but 28% of large residential care homes are rated needs improvement or worse, and that's only requires improvement or worse, and only then because they were caught out by the inspection. 35% of large nursing care homes require improvement or worse. So a very large proportion of care homes, and indicative of stats that we could cover elsewhere in the social care system, where improvements needed. Huge problems with access. So I think the most alarming stat here is that according to Age UK, 2.1 million of us will be living without the support we need to live a good life by just 2030. But we know that huge variation in access comes down to other things like levels of fees and charging regimes, so big problems there. Ownership and instability. So the huge shift to the, 2 huge shifts, one to much larger care providers. So I point to research showing that large care providers with less kind of relationship with the people who draw on care are far worse at providing high quality social care. but also those funded by private equity, a massive problem in terms of instability and some of the most awful kind of instances, set pieces of systematic failings in the social care sector can be traced back to that private equity model, the instability it embeds, and the fact that you can't expect private equity to work in the way that it's theoretically meant to in a sector where there aren't huge profit margins and there aren't meant to be huge profit margins. So a real challenge there. And lastly, workforce. And there was a lot of qualitative work that went into the 5 health frontiers, and some harrowing stories in the research from people around, of course, pay and training and progression, and their whether they feel on the one hand exploited, on the second hand supported in their role. One that stuck in my mind, someone called Jenny, whose name I've changed, talked to me about the book and described an instance, having just recently graduated and moved city, working in for a private care provider, and being asked last minute to take over a shift, traveling to a part of London that she wasn't familiar with, and not knowing the person that she was about to meet, and not then being able to communicate at all with the person because there was they didn't speak the same language. So what she described as a truly traumatic incident all round for both parties, but one she regaled as a trauma, one that left her to leave the sector. So indicative of that final structural problem. Now, the interesting kind of question on, I think, care is, where and how far do the current policy instruments that we have go? And I think the National Care Service has some interesting kind of first steps involved, particularly if it's defined in its broadest, most ambitious sense. So I think the principles within the NCS, the National Care Service, of making sure that care is provided by ethical providers, that it's free, and that it's delivered at the point of need, like the NHS, is very encouraging. But I think there still remains a big problem, and this is where the frontier really is, with how ambitious that really is. So if we think of, as I've just pointed out, the care sector as fundamentally problematic in terms of the types and the structure of care that exist, then the National Care Service might inadvertently, I think, make more accessible a model of social care that's already broken. And I think if we were to think about, if we go back into history, the challenges that were faced, say, around mental health care in the Victorian era, if the extent of ambition had been to make the asylum model of care free and accessible to all, then there would be huge problems there. So the question has to be not only about how we make social care free, universal, but also how that can be mapped against a fundamental transformation in the quality of that care driven by the people who draw on it. So, sorry.
Well, do you want to finish, and then I'll, because you come to a point that I really wanted to pick up with you here.
Yeah, no, why don't we go from there, Rick? Absolutely.
So I don't know. So the Reclaiming Our Futures Alliance have done a massive piece of work, creating the blueprint for a national independent living support system that modelled to some extent on the Independent Living Fund, but scaled up nationally, and basically replace social care as a separate, like an NHS for social care, as it were. But the important thing is it's talking about independent living, because it's, as you talked about there, is that kind of what we're stuck with is like going, how do we rescue this sort of bare minimum provision? Is that really the extent of our ambitions? Surely, actually, what we want to do is institute independent living, free at point of need for everybody who needs it, paid for, by progressively, would hope, and run as a national service. And And I think one of the things in terms of the history of the disabled people's movement, I think there's some desire that it would actually be separate to the NHS. So that the idea that the medical model is not dominant through how they provide for your needs, because we work from the social model of disability, and it's really a radically different way of thinking about things. But so that idea, which I think really ties up with your kind of your health New Deal, rather than defending this sort of bare minimum system, should we be aiming for much bigger, more cohesive, in this particular case, independent living system?
Yeah, I think that's spot on. And in the book, there's a trace back to the divergence of the system, and it's the Allied Services Act implemented by Clement Attlee. And the interesting thing there is that it sets care services, social care off on an entirely different kind of trajectory to the National Health Service that's formalised as the NHS, and that we all associate now with Aneurin Bevan and has been kind of heralded, in many ways. But the problem with the Allied Services Act is that it embeds a couple of things that, whilst not broadly done at the time, so things like the ability of local authorities to charge is present from that act forwards. The different delivery mechanisms of social care and its fragmentation from the NHS, those things are all there and present at that point. And those are things that local authorities don't tend to charge between the late 1940s and through into the 1970s. That's not very common, but it is an opportunity, and the ability to do so is something that kind of facilitates the Thatcher-style reforms of social care that really we recognise as the source of this very fragmented, very private sector-led, quite high leakage and quite minimal provision in terms of free public provision in terms of core entitlement that we have now. So I think the idea that correcting some of that by going back to the fundamental principles of the NHS for social care delivery is right, and focusing that, I think, on the right to independent living, that feels like fundamentally the right starting point. And I agree, Rick, that making sure that isn't a medicalised model is right as well. I think there are lots of reasons for that. There's the kind of what care actually looks like question, because a medical model might not be the right thing. But there's something else, isn't there, around one, do we need to make sure that social care has its own story so that we can build, particularly on the back of the pandemic, the public support and appetite for care specifically that has been so important to sustaining the NHS, that kind of popularity, public opinion point. But we see how wrong an over-medicalised model can go elsewhere as well, don't we, in terms of when GPs, as Jack Monroe so brilliantly pointed out, start prescribing food, and the kind of difficulties of adapting that model to a different question, and one that's wrapped up in social injustice is very, very difficult. So yeah, I think that's exactly the right direction, and a correction of a missed opportunity from 70 years ago in many ways. Great. Was someone about to come in? Or I can keep going from there.
Yeah, it's Carlo. I don't know if you can hear me.
Yeah, loud and clear.
I take on board most of that, but the trouble is the public have a very limited kind of channeled perception of social care, like things being done to people. And the assessments are too adversarial. And that is also an element of social care as it stands now that needs reviewing and restructuring, because there's a real fear year to year of ongoing cuts as well as the charging.
I think that's right. And you know, to kind of segue it back into the book. I mean, I think one of the shifts that's one of the evidence bases, the emerging evidence bases that's quite interesting, is the power of democratic ownership in making sure that, you know, as exactly as you say, Carlo, that care is done with people rather than seen as something that's done to people. And I think there's organisations like the New Economics Foundation, research from the University of Manchester, that suggests some very encouraging ways forward that harness, you know, in the way that I suppose things like private equity have been used to develop a care system that looks one way, but there are opportunities to use other ownership models to develop care that looks very, very different. And I think there's huge potential if we're thinking about, you know, what does universal free care look like, to think about, okay, well, there's probably a role for state, there's probably a role for democratic ownership, for cooperatives, for some of those models as well. Some of those that have shown to be much better at that kind of care with people approach.
Carlo, it's Helen here. I've had to take over from Rick Burgess as our chair because apparently Rick's connection has gone, unfortunately. So we've lost him for at least temporarily. So I'm just gonna just our luck. But yeah, did that answer your question, Carlo? Because is that okay?
Yes, but it's just worrying that the public perception, these discussions, I mean, it's good that we're doing it now, but the public don't even seem to understand about personal budgets and direct payments as they are now. But yes, your intervention, as far as it was, has been helpful. Yes, thank you.
Excellent, thank you very much. So Chris, just until Rick hopefully is able to rejoin us, I was just wondering if I could ask you if you could say something about the research that you've done that's in your book on the disproportionately high number of British lives, UK resident lives that were lost under the pandemic. And I was just wondering whether or not we could talk about the disproportionate rates of disabled lives in particular that were lost.
Yeah, absolutely. No, great question, Helen. And I mean, the numbers are changing all the time, aren't they? At the time of writing, the analysis in the book showed that that a hugely disproportionate number of deaths had come from the UK from COVID-19. So around 1 in 25 globally, which is a shocking number. We only make up 1 in 100 in people in the world as a country, so a very large number. The really worrying thing is then obviously the distribution of those deaths and how many of them we can now establish were avoidable. So we know that a very large number were I mean, the data on disabled people and COVID is limited, and the data is always a very tricky thing anyway, as I know you'll know. But if we look at those people drawing on social care, tens of thousands of deaths in the first peak of the COVID-19 pandemic, and then very, very compared to that, relative a lot less in the second peak and the third peak. And what that suggests to me, to others that have looked at that, is that much of what happened in the first wave was entirely preventable. Many of those deaths were preventable, and many of the preventable deaths happened in line with the existing inequalities that exist in UK society overall, which is alarming. I think it comes down to a couple of things. It comes down to capacity in the NHS for as a starting point, but that's not the only factor. So we know going in eve of COVID-19, after a decade of austerity, that there were less beds, less hospital, less nurses, less doctors, less emergency care beds, less bits of equipment, diagnostic machinery, in the UK compared to other countries of similar kind of the most comparable countries. We know that in social care, the fundamental kind of structural challenges that I've outlined were hugely were just essentially weaknesses. That protective ring that got flung around social care amounted to next to nothing, and so travesty struck. And we also know that the UK kind of population, one of the consequences of austerity was that it cut the budgets of the departments outside health and care that are most important, that we know that are most important to good health, so education, social security, universal credit, all the whole gamut of benefits, things like that. And in turn, the UK had, at a population health level, some of the West Health, and we're thinking how that intersected with COVID-19 going in as well. So another thing that underpins some of the shockingly high mortality the UK ended up with. Yeah. Oh, sorry, Helen, I think you might be on mute.
Chris, can I ask you, in your view, has the pandemic led to an intensification of political will to turn back austerity or not?
That's a brilliant question. I think the answer is I'm increasingly pessimistic about that. And about how much of an opportunity this will really be to break the status quo. So one thing that really cements that is that in the same breath as the health and social care levy was implemented, the same week, I think, or a week apart, the UC uplift was withdrawn, and that's essentially a return to a system where there's a little bit, but by no means enough funding for the NHS. We have to remember that austerity didn't mean a real terms cut in the NHS. It just meant the NHS didn't get enough funding to keep up with increasing population health demand. But the storing up of health need because of that UC cut, and we know that the evidence is very clear that will mean that will have consequences down the line, is a return to that logic. And we've seen the Treasury prove an obstacle in terms of funding. We can go to the Living with COVID plan, which had all kinds, the fingerprints of the Treasury vetoing spending all over it. And I think that's alarming, because the final, I suppose, riposte of the 5 health frontiers is just the sheer risk of health shocks in the future. If we think of COVID-19 as a health shock, I remember in 2020 there was lots of talk of people calling it a black swan event. It's the kind of once in a lifetime thing that you just can't prepare for. Who could prepare for it? And the government used that quite explicitly. But the latest evidence is that in terms of COVID-19 style pandemics, the risk is now 2% a year. So someone born in 2019, they can expect 2 more COVID-19 level incidents. And we know that things like antimicrobial resistance, taking away kind of antibiotic options and other treatment options that have proven hugely useful in the last 100 years, the just shocks coming down the line are immeasurable. And the risk is that we're going back with exactly the same NHS capacity questions, the same social care challenges, because frankly, the reforms do nothing to address the reasons and learn the lessons of COVID-19, and the same wider population health challenges for the decades to come.
Thank you, Chris. So we've got just over a quarter of an hour left, and one of the things I just wanted to quickly ask you about before we open it up for questions was this. I know in your book what you've done is look back to the global financial crisis of 2007, 2008, and the impact that had upon climate change activists, and the way in which it kind of shifted their approach to campaigning from, broadly speaking, a sort of defensive position to a more assertive position. And I think in your book, what you do is draw some useful parallels between that shift and what we need to be doing as health and social care campaigners and activists.
Yeah, I think that's right. So, so the transition I'd really like to see is very similar to the one that we see in climate activism in the 2000s, you know, and before the 2000s and through to the 2000s, the noughties. We see a climate activism that's struggling quite a lot, especially given the size of the challenges it faces. It's a movement that is predominantly focused on save the planet. And one of the kind of, you know, the archetypal figures of that save the planet climate activism is Al Gore. And of course, we see it narrowly comes close, doesn't it? But painstakingly loses. And there's a big transformation in that, what we might band as still broadly a defensive approach, save the planet, save the NHS. There's a big transformation in 2008. And the financial crash catalyzes a new type of activism on climate that is focused on a few things. So the Green New Deal is several things that we can learn from. Firstly, it's a cohesive package. So it sets, instead of trying to boil the ocean, and I often make this remark more around the kind of health inequality, social determinants point, that trying to do everything, solve all inequality, it's a very big challenge, and one that makes it quite hard to talk to people about. The Green New Deal is a package of instruments I don't think does everything, but it gives people a foothold, something to jointly campaign on. So I think that's incredibly useful. The other thing that it does is it starts employing framing to its huge advantage. So it starts talking about climate in terms of being good economic sense. Climate activism becomes the economically sensible activity. It talks about it in terms of good health. It talks about it in terms of job creation. All incredibly useful things, I think. So I think if we're thinking now, okay, 2008 financial crash led to that shift. Well, we've now had a huge emergency that, from a health activist, care activist perspective, you know, very, very much brings us up in political salience and gives us an open door. And we have to think about, what does our learning look like? And I think that's where the public health New Deal comes in. So I think what we need is some of this related to the NHS, some of it around what flourishing, brilliant social care looks like, some of it around how we can tackle inequalities and some key demands for inequalities, some of it around the future of sustainable global health systems. So thinking about the threats that come down the line, but a similar package of policies that we can band in the same way, Green New Deal, Public Health New Deal, as a way to transform society, transform the economy, and that we can pitch as economic good sense. Because I think, you know, there's a huge unstated thing here that as much as austerity tried to present social care, good health, the NHS as a cost to be contained, something we can only afford if we're really rigorous, we've now, you know, the emperor has no clothes. The cost of those policies over the last 10 years will now outweigh any short-term benefit we could have seen. So we can present them as economic good sense.
Excellent.
Sorry,
you'll be pleased to look. He's back. Rick's back. You'll be pleased.
Yeah, my internet suffered a catastrophic privatization, shall we say. Thank you, Helen. Do you want to stay on as co-chair? Because I think like you will have caught things I missed.
I do not. No, please.
Oh, God darn it. I think a key question is about funding, Chris. When we make these, you know, more profound demands of independent living, of a social justice response, you know, you get this sort of treasury view of pennies, and you know, this utterly false idea that the national economy is like a household budget and there's a limited amount of money and all this kind of thing. How do we make the case, the economic case for this?
I'm really glad that you've mentioned the treasury. I am ever more of the view that fundamental reform won't be possible with the treasury in its current format. I think the tension that exists between the very powerful short-term role of Treasury to manage annual fiscal statements and the money going into elections, general elections, so the short-term cycles of our system mean it's entirely incapable of looking to the long term. And lots of the things we're talking about here today, lots of the benefits of good care, good social care, good health are only felt in the long term. So there's a fundamental challenge there. So my increasing thinking is that we need to think fundamentally, probably, if we're thinking theory of change and the very root cause, I think we need to think fundamentally around the organisation of state. So I think it is very in scope for social care campaigners to say, look how the short-termism of the Treasury is harming us over long time periods. And the last 10 years, the cost of the decisions that we're taking to austerity is one case in point of that. So reform of the Treasury seems like a good idea. The other thing that we can do is appeal to core kind of economic outcomes. And I think there's a very powerful case going forward to do that. We know, for example, that the government is dreadfully worried about kind of, is very worried about. I've lost my my train of thought of what the government are worried about. It must mean they've got lots of concerns.
That's okay. We quickly kind of tear through sort of questions we've had. I think came up earlier was, to some extent, surely we're at this point because of historic underfunding of the NHS over a long sustained period and constant political restructuring. So to some extent, are things maybe not as bad as they are? They're just being presented as bad because simply not enough money has been provided for it.
I disagree. It's Carlo again. I think. Hi, Rick. Sorry. With all that we're saying about continuing austerity, really, albeit under the radar, it lends very much to the fact that, in terms of the government, that our lives, it seems to me, are disposable, and that's an impression that is really, really hard to get away from. Witness is the enforced do not resuscitate orders that have been taking place widely over the pandemic. Surely we need to keep addressing that in activism and the funding, but it's not. Obviously, it's related, but it's not all about funding.
Yeah, I'm going to come in here. This is Rona.
Yeah, Rona.
I completely agree with Carlo. I used to work for Health Watch during the beginning of the pandemic, and I was seeing a lot of, not so much in the area where I was working, but I was hearing a lot of stories of people being admitted to hospital, not necessarily with COVID, but if they had a learning disability, they were either put down automatically as do not resuscitate without even being asked their carer's permission or their permission. It was just an automatic do not resuscitate. And that also seemed to apply to people over the age of 70 as well. And that was like a blanket decision that was being made by the NHS. And we campaigned very heavily against it. And we managed to get it stopped in the area of Health Watch where I was working. And then, we basically sort of wrote letters to sort of like get it stopped on a national level. And it kind of eventually it just sort of trailed off. But a lot of people use the E word, eugenics, to describe what was going on at that time.
Yeah, thanks, Ron. I think we all felt, I think we still do feel actually, and particularly in this kind of return to normal thing, that for the people who have to continue to shield, who are at risk, people have just been written off and aren't valued. So maybe part of this campaigning, part of this idea is also to confront this thing that we've had successive governments that are deliberately not valuing whole sections of the population's lives.
Yeah, I think that's only very narrowly touches on it, but the statements that were being reported by the Care Quality Commission is astounding and symptomatic of an evaluation of them. So I couldn't agree more.
Chris is not audible. Chris is not remotely audible. Can everyone please mute?
I'll just jump in, Chris, for a moment. It sounded like your feed was inaudible.
How am I doing now? Is that any better?
You're back, Chris. You're back.
Yeah, you're back. And if other people, if you're not speaking, please go on to mute, because there's some people here who are very sensitive to any background noise. Thank you.
So I was just agreeing with the points that had been made. Really, I think the book only touches on it slightly, but the data that comes in from the Care Quality Commission around forced student resuscitate orders is awful. Really, it's harrowing, and there were hundreds reported by the Care Quality Commission, which I think they themselves admit is likely to be the tip of the iceberg in terms of what they can ascertain. So a really harrowing thing. And I think for me, it comes down to the consequences of something that, again, mapped out in there, which is the transition of the NHS between the 1980s and today towards a governance model, a governing model that is very neoliberal in its outlook, that is very focused on, competition, on short-term efficiency, on making things just about to get by with the very least resource possible, essentially on a combination of small statism and kind of competition, competition focused policies. You can trace that back to the Griffiths review in the 1980s and the emergence of theories from
Chris,
your sound's going again. I don't know if it's anything going on.
I think, Chris, it's probably what's the word? Yeah, not anything you got much control over. Your audio, Rick. We're coming up for the last few minutes.
Yeah, I think
Hannah. Obviously, we only managed to book one interpreter, so we do have to finish.
Yeah, so I think we need to.
So if you want to sum up.
Yeah. Just a note. I see there's definitely a common thread in the chat about actually campaigning and being able to be included in campaigning. So maybe a future meeting or workshop, we could actually do something around that. So I think there's some very interesting things we could do. But back to this particular issue, what are the next steps to tie up Disabled People's Movement with the world you move in of sort of think tanks, policy analysis, radical publishing? Where should we be going next now with this, Chris?
Yeah, great. Hopefully, I think is one step. So thinking about the vision look.
Sorry, your audio's gone again.
Your audio's not working very well, and for some people it won't be accessible. So Rick, maybe if you just finish on some final comments, and if Helen wants to come on as well.
Yeah, Helen, you come on, because you've been a major driving force behind this. Give us your wrap up.
Okay, well, firstly, I just want to thank John, who is actually technically at least on leave today, for coming to be with us tonight and to do all our technical support. So thank you very much, John. Thank you for everyone at Inclusion London who've been working so hard for many months now. We had an interesting turn of events in the House of Lords last night on social care. John, do you want to just very, very quickly explain what happened there?
I was on leave, so I'm not fully up to date. But the government was defeated, and it will have to return to the Commons, which is a huge opportunity for those of us who are involved in campaigning. So I won't go into the technical details, but we will be updating everyone. But it means that the government plans got defeated in the House of Lords last night. So it will go back to the House of Commons. So there's another big opportunity to put pressure on MPs over the coming weeks. And I'll be in contact with everyone at the end of the week.
I think that's maybe a brilliant thing to, and as Rona has said in the chat, thank the Lord. So some good news there. Thanks a lot. Thank you very much to Chris. Sorry that we seem to have had terrible internet this evening. Maybe something's going on. Be great to follow up with this and continue this kind of the communications. I think common experience for a lot of us is we sometimes go to meetings and it's unions, it's political parties, it's analysts, it's researchers, and they almost never invite disabled people. So I think it's important that we actually become the leading voice on this. Anyway, thank you everyone for coming. We have now run out of time. Please, everyone, look after yourselves, and hopefully we'll keep fighting, and one day we will get that better system. Thank you.
Thank you very much.